Arm lead inversion. Right arm lead placed on the left arm and vice versa can be recognized by inverted P waves, negative QRS and T waves in lead 1. The same pattern can be seen in true dextrocardia as well. In true dextrocardia, the chest electrodes will not show the usual progression of R waves. Instead, the QRS amplitude will progressively decrease from V1 to V6 as the heart is on the opposite side. Simple option is to get a repeat ECG for verification, if possible under direct supervision. Arm lead inversion or technical dextrocardia is one of the commonest errors in ECG recording. This ECG has features of arm lead inversion mentioned above. Negative P, predominantly negative QRS in lead 1 with negative T waves, and upright waves in AVR are seen, but chest leads show normal progression from V1 to V6. In addition, this ECG also shows narrow Q waves and prominent T waves in lateral leads with mild concave upwards ST segment elevation. The S waves in lead V1 are deep and the R waves in V6 are tall, possibly an evidence of left ventricular hypertrophy by voltage criteria. Most commonly recorded ECG is a 12-lead ECG. 12 leads in a standard ECG are as follows. Standard limb leads 1, 2 and 3. Augmented limb leads AVR, AVL and AVF. Chest leads V1, V2, V3, V4, V5, V6. Thus, a standard 12-lead ECG does not include right chest leads known as V3R, V4R and V5R etc. But in most cases, 12-lead ECG includes a long rhythm strip, either lead 2 or V1 or both, for facilitating rhythm analysis. If the ECG machine has only a single recording channel, 12 leads are recorded sequentially. More sophisticated recorders have facility to record 3 or even 12 channels simultaneously. Simultaneous multi-channel recording can record all leads of a single beat and is better for analysis of complex cardiac rhythm abnormalities. Electrode combination for limb leads are as follows. Lead 1, left arm positive, right arm negative. Lead 2, right arm negative, left foot positive. Lead 3, left arm negative, left foot positive. Diagram illustrating the positive and negative poles of the 3 standard limb leads. Note that right arm is negative for leads 1 and 2. Left foot is positive for leads 2 and 3. Unipolar limb leads are derived using the limb lead electrode potentials. All the 3 limb leads are internally connected to a central terminal, Wilson's central terminal, using fixed value resistors. Usual limb lead recordings are called bipolar recordings, with one limb serving as positive electrode and another as negative electrode, as illustrated earlier. Unipolar recordings are obtained by taking the limb electrode as positive and central terminal as negative. Unipolar limb leads are called VR, VL and VF depending on whether the positive electrode is at the right arm, left arm or left leg. Voltages of these recordings can be augmented by disconnecting the connection to the corresponding limb electrode from the central terminal, causing almost 50% increase in the amplitude of the recordings. The augmented limb leads thus generated are called AVR, AVL and AVF. Augmented limb leads were described by Goldberger in 1942. Chest electrodes are placed on the anterior chest wall as follows. V1, 4th right intercostal space, right sternal edge. V2, 4th left intercostal space, left sternal edge. V3, midway between V2 and V4. V4, 5th left intercostal space, mid clavicular line. V5 anterior axillary line, same horizontal level as V4. V6 mid-axillary line, same horizontal level as V4. Approximate positions of chest leads displayed in relation to a chest X-ray. As the cardiac size is a bit on the lower side in this X-ray, V4 appears to be a little away from the cardiac silhouette. Chest leads are often positioned at varying positions by different operators due to difficulty in ascertaining intercostal spaces accurately in obese patients and females. This may cause difficulty in comparing serial ECGs. Hence, every effort should be made to place the electrodes accurately. In some situations, when accurate comparison of serial ECGs is needed, marking the position with a skin marker pen may be needed. Chest leads are named C1, C2, C3, C4, etc. by some manufacturers. Here, C would stand for chest. In the conventional naming system, V stands for voltage. Conventionally, right arm electrode was given a color coding of red, left arm electrode yellow, left leg electrode green, and the neutral electrode in right leg was given a black color. But current manufacturers sometimes use different color coding systems so that one has to verify the letters written on the electrodes before using them. RA for right arm, LA for left arm, LL for left leg, and RL for right leg. Moreover, a previous user might have changed the position of clips attached to electrodes so that the color coding can be misleading. Hence, it is essential to make sure of the lead connections to the ECG machine before recording the ECG to avoid wrong lead placements, which is the commonest technical error in ECG recording. 12-lead ECG showing normal pattern of P, QRS and T waves. In AVR, all the waves are negative. Most other leads show positive waves. Here the T wave is flat in leads 1 and V1 and inverted in AVL. Normal precordial QRS pattern is seen. Minimal upsloping ST depression seen in inferior and lateral leads may represent superimposition of atrial repolarization or TA wave. ECG monitoring leads are different from the usual leads used for recording a 12-lead ECG. This is because monitoring leads are used mainly for rhythm analysis and sometimes for ST segment monitoring to look for ongoing ischemia. Any lead which can show the P waves, QRS complexes and T waves well can be used for ECG monitoring. Often the monitoring lead will have to be tailored for each individual. It may be worthwhile to look at 12-lead ECG and decide on which lead is likely to give the maximum required information for that particular person. Most intensive care units monitor only one lead, while some resort to 2-lead monitoring for better arrhythmia analysis. All 12 leads are monitored during an electrophysiology study as well as during a treadmill exercise test. Several types of lead modifications are used depending on the situations. In the coronary care unit, modified lead 2 is usually used. Modification is that the limb electrodes are placed on the proximal parts of the limbs or adjacent torso rather than over the distal part of the extremity in order to reduce artifacts due to limb movements. Most modern monitors have the option to use chest leads in addition to limb leads. When chest lead monitoring is needed, additional electrodes are placed on the chest. Chest lead monitoring is useful in picking up ST segment changes. Location of the leads depending on the type of patient. While anterior locations are available in the coronary care patient, a surgical patient may require different locations depending on the location of surgical incision and dressings. Esophageal leads may be used in some rare situations to decipher difficult arrhythmias. Mason-Likar modification of 12-lead ECG is most popular during treadmill exercise test. It can also be used in the electrophysiology laboratory. In this lead system, Limb electrodes are placed on the nearest location on the torso to prevent movement artifacts during exercise. Chest electrodes are placed in the conventional positions. Difference in pattern of the modified 12-lead ECG mandates caution while trying to interpret Q waves and other abnormalities on a Mason-Likar modification. Approximate positions of the limb and chest electrode in Mason-Likar modification. Lower limb electrodes may be placed a little lower than shown in the figure. The QRS axis has a rightward shift due to the upward shift of the lower limb electrodes, but there is no difficulty in interpreting ST segment shift and arrhythmias during a treadmill test with this lead system.